All right, good morning, everybody. We'll get started today with our grand rounds. Welcome back. Thank you to everyone who has come out in person. I know it's very tempting and very convenient to watch it on Zoom, and we love that we have a great Zoom audience, but I wanted to give a quick plug for our in-person viewing. It's just wonderful for our speakers to be able to speak to actual faces. As you can imagine, it's hard to speak to a screen all the time. So if anyone wants to come in person, we are in person every week. Of course, we'll still have the Zoom links, but in person in the Farrell Learning and Teaching Center, usually in the Holden Auditorium for this half of the academic year. And then our rooms will likely change after that. But Holden Auditorium in person every week, 8 a.m. Would love to see your faces. Otherwise, thank you for joining on Zoom. Today, we do have Professor Altayar from the GI department who's going to speak to us about celiac disease. And it's going to be a very special talk because Dr. Altayar is, of course, an expert in luminal GI, having completed training both here at WashU and at the Mayo Clinic, and also brings a unique aspect of a computing analytical background as he's now completing his medical informatics fellowship. So he has a great range and breadth for which he's going to talk to us about celiac disease. Thank you.
Thank you, Stephanie. Good morning, everybody. Thank you for being here, and thank you for inviting me as well. This is a topic that I'm really passionate about, and I'm hoping to share my passion with you. Okay. So I have no financial disclosures. I have few objectives that I'm hoping to achieve by the end of this talk. I'm going to highlight some of the disparities in the diagnosis of celiac disease. I'm going to talk about when to suspect celiac disease and test for it. When we have somebody on a gluten-free diet, how can we evaluate if they have celiac disease or not? And I'm going to discuss the controversial issue of obtaining biopsies for individuals with celiac disease. And I'm also going to discuss a little bit why is it important to make an accurate diagnosis for celiac disease. I'm just going to go through a brief history. So it's believed that the disease was described in the 2nd century AD by Aristeas of Cappadocia. Aristeas at that time thought that the disease only affected adults and described patients who had chronic pain, diarrhea, and failure to thrive. His treatment was fasting and rest. He actually hinted that bread was difficult to digest without drinking in those patients. Running through history until the last century, we have learned a lot about celiac disease since then. Starting with the identification of gluten-free diet as a treatment for individuals with celiac disease. Then the identification of concordance in monozygotic twins who had higher concordance rate, in addition to the identification of the HLA molecules that are required to have the celiac disease. Then the identification of antibodies that could be used for testing and evaluation of celiac disease. The most recent ones are the tissue transglutaminase, which is widely used. With this also, our knowledge about the pathogenesis of celiac disease has improved. We know that the degradation of gluten leads to formation of certain peptides, including the gliadin. This gets deaminated by the tissue transglutaminase that is taken up by, then the deaminated gliadin gets taken up by the antigen-presenting cells and presented to the T cells, which starts the immune cascade and inflammatory process, which leads to the known changes that happen with villus atrophy and crypt hyperplasia. The diagnosis of celiac disease have evolved a lot over time. We talk about symptoms responding to gluten-free diet. There are serological tests, there are small bowel biopsies, and even genetic screening. This is an exciting time for individuals with celiac disease. There's a lot of trials happening on different treatments. So there are trials targeting different pathways. Some of them are in phase 1, some of them in phase 2. This is just from the Beyond Celiac website. They have all these trials. We're part of some of those trials here also. Now, with that spread of knowledge and how much we learned about the disease, there are things that are changing also. This is from Google Trends. Google Trends is a tool in Google that allows you to look up how often people search certain terms. And what we're comparing here is in the United States, how often people search for celiac disease and how often they search for gluten-free diet. And what you can see that around 2006 or 2007, people started searching more for gluten-free diet compared to celiac disease. It's probably related to the proposed new rules by the FDA at that time to include gluten-free labeling on foods around that time. However, do all these people have celiac disease? Are we overprescribing gluten-free diet, or are people overprescribing gluten-free diet themselves? Those are some of the things that I'm going to try to discuss. And my hope is that I'm going to take you through certain assumptions that we have that may be leading to some of those things that we're talking about. And we'll achieve the objectives of this talk at the end. So one of the assumptions is that people of color are not susceptible to celiac disease. If you look at data from all over the world, you can see that celiac disease is present in most of the countries. You can see that it's present in Northern America, South America, in Northern Africa, in European countries. There's a lot of data lacking from other countries, but the prevalence of the disease varies across, and it's present all over. The fact that there's no data from some of those countries does not preclude that the disease is present. For example, since this meta-analysis was published, there are studies from Sudan, which is Sudan in Africa, and Ethiopia, showing that there are patients over there with specifically type 1 diabetes who had celiac disease as well. So the disease is present everywhere. There are implications for this assumption. This is a study using the Clinical Outcomes Research Initiative database from the ASGE. This database is using data from endoscopy centers that send their endoscopy information, why the endoscopy was done, what was done during the endoscopy, quality metrics. And what the authors looked at is that patients who had a primary indication for obtaining biopsies for celiac disease, but they did not have any change on endoscopy, so obtaining random duodenal biopsies. And they tried to compare those, how often people did biopsies. What you can see here is that individuals that were white were more likely to have random duodenal biopsies obtained when they had an indication for biopsies. That included anemia, that included diarrhea and weight loss. And that was about 2 times more likely to have biopsies done. So are people of color at risk of having celiac disease or not? That's the question. We always talk about the permissive HLA genotypes. Sorry for the typo, it's HLA, not HLD. The HLA genotypes that are predisposed individuals to celiac disease. And this is a study from St. Joseph's Hospital in Denver. They looked at all the children that were born in between 1993 and 2004. And they looked at their HLA types, and they identified that actually the permissive genetics are present in all populations. It was in Asian Americans, African Americans, Hispanic, non-Hispanic whites. Now, the study actually attempted to follow subjects prospectively from who had those permissive genotypes and to see if they ever developed celiac disease. Unfortunately, that study ended recruiting mainly non-Hispanic whites. So we didn't have enough data about how often the disease is present in those who are predisposed from those other groups. This is another study that used NHANES database from 2009 to 2012. It included about 15,000 participants. At that part of time, they were obtaining celiac serologies as part of the NHANES study. They identified what we call celiac autoimmunity, so the presence of antibodies in those individuals who were screened. And you can see that the prevalence of having celiac disease is not 0 in those groups. So in non-Hispanic whites, it was 1%. That was the oversampled group in NHANES, but the other groups, it was not 0 and it was present. So the assumption that people of colors are not susceptible to celiac disease is not accurate. And when we have suspicion for celiac disease, we should still check for celiac disease. In fact, just to go back to that map, one of the studies suggests that people from the Indian subcontinent, from the Punjab area very specifically, are maybe at the highest risk for having celiac disease. Another assumption that we use sometimes is that only symptomatic individuals should be tested for celiac disease. This takes us back to the word celiac. The word celiac means abdominal, relating to the abdomen. So we always think about celiac disease in individuals who have certain abdominal symptoms. The implications of this assumption. So Mayo Clinic have access to a lot of data, and they looked at data from the Olmsted County. They had serum available from about 30,000 individuals. And what they did, they tested that serum for celiac autoimmunity. And the sera that were tested were from individuals who did not have celiac disease diagnosis. And they found that about 1% of those people who did not have the diagnosis actually had celiac autoimmunity. Now, what they identified also that looking at the charts that none of those individuals had typical symptoms or classical symptoms for celiac disease, that is diarrhea, anemia, or fractures. So we might be looking only at the tip of the iceberg when we're looking at symptomatic individuals. Another study from here that looked at individuals who presented to the GI clinic as initial office visits. And what the authors did is that they looked at individuals who got tested for celiac disease when they had an indication or a high-risk feature for celiac disease. And at the end, only about 40% of those individuals who presented to the GI clinic that may be at risk for celiac disease ended being tested for celiac disease. Now, how common is celiac disease? Celiac disease globally, we think, is present in about 1% of the population. In first-degree family members, there are different rates reported, but based on a recent meta-analysis that tried to pull all the data, it's about 7.5 to 8% in first-degree family members. Those cases of undiagnosed celiac disease are more likely to have osteoporosis, dermatitis piriformis, and other conditions that are not classical, non-classical GI symptoms. So when should we suspect celiac disease then? In anybody with GI symptoms. However, as I just mentioned, celiac disease is likely a multi-systemic process and involves multiple organs. One of the studies, a retrospective study from Ireland, looked at immune-mediated conditions that are associated with celiac disease and found different prevalence ratios compared to the expected numbers. So you can see that the prevalence ratio of certain conditions is about 12 times more, 5 times more, as low as 1.5 times more. But there are other conditions that are associated with celiac disease that should make us think about celiac disease. And many of those may not have symptoms of celiac disease. When should we suspect it? Just to build up on that, individuals with dermatitis piriformis, iron deficiency, folate deficiency, B12 deficiency, individuals with elevated aminotransferases, osteopenia, osteoporosis, especially at an early age, chronic fatigue, individuals with neuropsychiatric manifestations, specifically idiopathic neuropathy, persistent migraines, short stature. There's also some data that suggests that women with infertility, recurrent fetal losses, and low birth weight may have increased risk of celiac disease. However, the data is very debatable. When to consider celiac disease, again, what are the groups that are high risk? We mentioned first-degree family members, but also second-degree family members. We think they have higher risk. Certain endocrine disorders, type 1 diabetes, screening is usually for celiac disease is usually done in type 1 diabetics currently. Certain connective tissue disorders, inflammatory GI disorders, including autoimmune hepatitis, other conditions, for example, Down syndrome. Their data suggests that the celiac disease is present in about 6% of those patients. Now, we talked that many of those individuals may have no symptoms. So is it really worth it to make the diagnosis for them? When we overdiagnose, is it helpful here? There are a few studies that try to look at this. This study is from Finland. They looked at individuals who considered themselves asymptomatic, so they had no symptoms at all, and they tested them for the endomysial antibodies. And then they randomized them to gluten-containing diet or gluten-free diet. And they found that those individuals that were randomized to the gluten-free diet ended having less symptoms, even though they considered they had no symptoms. When they completed symptom screening before and after, they found that those individuals had improvement in their symptoms. Now, this study is not blinded, so there are limitations, but those were the findings from the study, at least. Another study from Mayo Clinic that looked at individuals with biopsy-proven celiac disease. And they looked at those individuals who had classical and non-classical symptoms, and how did they feel, how did the GI symptoms evolve after starting gluten-free diet. What they found is that all groups, whether they had classical or non-classical symptoms, had improvement in their symptom scores and improvement in their quality of life after starting gluten-free diet. Again, it's not blinded, this observational data. Finally, another study from Norway, it's a population-based study with repeated health surveys, similar to the NHANES. And what they did is that they identified those individuals that had positive, they had celiac autoimmunity, positive tissue transcontaminase, IgA or deaminase peptides. They invited them to have endoscopy. And then they compared those who had celiac disease to those who did not have celiac disease. Now, all those individuals had no symptoms. They were just part of the screening. None of them had diagnosis of celiac before. And they found actually that using those scores that individuals who had no celiac disease had more symptoms than the individuals that had celiac disease. They also found that their quality of life was worse in those individuals without celiac disease. Now, when those patients with celiac disease received gluten-free diet, their symptoms improved, even though they considered themselves asymptomatic, and their quality of life as well improved. This data suggests that many of those patients, which is something that we see in clinics sometimes, who think that they have no symptoms, once they start gluten-free diet, they recognize that they had some symptoms when they improve, especially when they get exposed to gluten. Sometimes patients report that previously I thought that I didn't have symptoms. Now when I get exposed to gluten, I have symptoms. So screening those who are symptomatic only may be looking only at the tip of the iceberg, and we may be missing patients with celiac disease, or actually maybe missing more patients with celiac disease. Another topic that is also controversial is the clinical response to gluten-free diet. Is it sufficient to diagnose a patient with celiac disease? So sometimes a patient will see a clinician and will say, well, why don't you try gluten-free diet? And if you feel better, maybe you have celiac disease or you have gluten intolerance without formal testing. This takes me back to this trend from Google, the trend that I showed you from Google Trends. And I actually wanted to see what the trend looks like when you look at the world completely. You will see that there's variability across countries. For example, in the Northern American countries, the people search more for gluten-free diet than celiac disease. But in certain countries, for example, Sweden and Italy, where celiac disease is also very common, people search the other way. This is from Italy, for example. You will see that people are searching more for celiac disease than gluten-free diets. The colors are flipped here. The reason I'm bringing Italy specifically because the following study is from Italy, where people are searching less for gluten-free diet and more for celiac disease. In this study, they looked at those individuals without celiac disease who were on a strict gluten-free diet. And then they randomized them to a gluten-free flour and a gluten-containing flour. And they gave them 10 grams for 10 days of each. Then they put them through a washout period for 2 weeks. And again, they let them cross over to go to gluten-free flour and gluten-containing flour. Now, all these individuals did not have celiac disease. It's known that they don't have celiac disease, and they are on a strict gluten-free diet. The findings were interesting because about 17% had, or 6 of those patients, 6 of the 35, had no symptoms at all, regardless of what they received. About 49% of those individuals developed symptoms when they received the gluten-free flour only. And about 35% of those individuals developed symptoms when they received the gluten-containing flour. So the fact that the person doesn't have celiac disease does not preclude them from knowing that they are receiving gluten sometimes when they are sensitive to gluten. Maybe those are the individuals that have non-gluten celiac sensitivity or non-celiac gluten sensitivity. Another study, building on that. So in those individuals who had a symptomatic response to gluten-free diet, this is a study from the Celiac Center at Beth Israel in Boston. They looked at those individuals who had response to gluten-free diet in their symptoms, and that response was sustained for 3 months. And when they got exposed to gluten, they felt symptoms. So those patients are that arm that feels the gluten, at least as reported by the patients. What they did, they looked at their what workup was done for them. And some of those individuals had abnormal serologies. Some of them had borderline serologies. Some of them had negative serologies. And then some of those underwent biopsies. The people with abnormal serologies and borderline serologies, many of them ended being diagnosed with celiac disease. Those with negative serologies ended having HLA testing. Oops, sorry. Some of them ended having HLA testing. The others who had non-revealing biopsies also ended having HLA testing. If the HLA testing was positive, they called them indeterminate. Those who had villus atrophy but negative serologies ended either being diagnosed at the end with seronegative celiac disease or non-celiac enteropathy. And finally, those who had HLA negative or had normal biopsy, they ended being having non-celiac gluten sensitivity. So those individuals who have symptomatic response to gluten-free diet and when they get gluten, they feel symptoms. About 50% of them ended having non-celiac gluten sensitivity, and only about 40% of them ended having celiac disease. In other words, our response to gluten-free diet in terms of symptoms does not predict celiac disease. Okay, I mentioned HLA, so I'm just going to discuss it a little bit. So there are certain HLA genotypes that are known to be associated with celiac disease, or are actually required to have celiac disease to present the antigens that are needed. And there are different HLA types. Some of them are, that have different risk depending on what you have. So if you're a homozygote for DQ 2.5, or if you have a DQ 2.5 and DQ 2.2, you're at the highest risk. Then you have the DQ 8 homozygote. Then you have the heterozygote. And then finally, you have the DQ 7.5, which is the most rare one. Now, when I'm saying very high risk, that term is very loose. Very high risk may mean 90%, may mean 80%. I don't know what it means. So I really wanted to share this table with you. I know the numbers are not clear. But in the group that has the highest risk, those are based on studies. In the group that had the highest risk genotypes, the risk is about 1 to 7 to 1 to 14. So it's not more than 90% or any of those numbers. It's really on the lower end. In the group that had the lowest risk genotype, the risk is about 1 in 209 to 1 in 1800. So the use of HLA alone to make the diagnosis of celiac disease is not helpful. The use of HLA should be to rule out disease. So in those individuals on a gluten-free diet, as I showed you earlier, you can use HLA to rule out celiac disease and tell them it's extremely unlikely that you have celiac disease. It may be used in certain controversies when we have discordance between the biopsies and serologies, and some studies have used it in screening as well. So to recap all this, this is a proposed algorithm by that study from Beth Israel. They said, well, and I just modified a little bit to make it more simple. If somebody has a symptomatic response to gluten-free diet, you look if they had serologies. If they didn't, you go with the HLA testing. If it's negative, they don't have celiac disease. If it's positive, you do a gluten challenge. I'll talk about gluten challenge briefly. If they had serologies before, you look at what the serologies were at the time. If they have HLA positive, you could also go to the serologies as well and see what their serologies at the time when they're seen. In those with negative serologies, you do HLA testing. If it's positive, you do a gluten challenge. If it's negative, you have non-celiac gluten sensitivity. In those with borderline serologies, again, you use HLA. If it's negative, it's extremely unlikely that they have celiac disease. If it's positive, you do a biopsy and you make the diagnosis of celiac disease, the same for abnormal serologies. So what I'm hoping to show here is the role of HLA. It could be used especially in those patients on a gluten-free diet, or those patients who have findings that are debatable for celiac disease. You could use HLA testing to assist you in the diagnosis. Okay, what is a gluten challenge? Historically, a gluten challenge is given a patient 10 grams of gluten a day for 6 to 10 weeks. How much is it? 10 grams? It's about 3 to 5 slices of bread. There were studies that were done on this, though, to utilize that challenge in clinical trials. And I do this actually in clinic relatively frequently, I would say, when somebody comes in with the question about celiac disease, and I tell them, let's do a gluten challenge. People are usually concerned about this. And I would try to explain to them frequently is that if we can do stress testing and make people run on a treadmill when we're suspecting their heart is sick, we can do a gluten challenge. So they got exposed to 3 grams or 7.5 grams in this study of gluten for 2 weeks, and they look at their symptoms. At day 3, most people had symptoms who had that. Those are individuals with confirmed celiac disease. By day 14, half of them had change in the serologies. About half, a little bit more than half, had change in their biopsies. They didn't do biopsies at day 28, but by day 28, I would say about 85% had a change in their serologies or biopsies. So that could be used in clinical practice. It's used more in trials. There are additional gluten challenges that were done, 10 grams versus 3 grams duration. Different studies have been done on this, but we do this in practice sometimes. So the clinical response to gluten-free diet is not sufficient to diagnose celiac disease, as I showed you. That's a place where we could use HLA testing. That's a place where we could use a gluten challenge as well. Okay. Another assumption that we have is that the presence of celiac disease antibodies is sufficient to diagnose celiac disease. This is currently a hot topic with a lot of controversy. Actually, from 2021, there was in the New England Journal of Medicine, they had this clinical decisions piece where they brought up an example of a patient who had heartburn and family history of celiac disease and had abnormal antibodies. Then they asked two experts to advocate for either recommending gluten-free diet or not recommending gluten-free diet. They did not discuss additional testing. Okay. To discuss this issue, we're going to talk about how we make the diagnosis of celiac disease. We talked about symptoms and how they really have minimal role in making the diagnosis. We talked about the role of genetic screening. So what I'm going to focus on now is the role of serologic markers and the role of small intestinal biopsies and the limitations as well. Serological markers have evolved over time. Early 1980s, we had the anti-native gliadin antibodies. They're rarely used now. Then we have the endomysial antibodies. They're expensive, but poorly standardized. In mid-1990s, we had the tissue transglutaminase antibodies, which are the most commonly used ones now, cheaper and became more standardized over time. They used to be less standardized previously. And then the most recent ones are the deamidated gliadin peptides, which are more expensive than the tissue transglutaminase. And some studies argue they're highly sensitive and specific. This is an old article that looked at the sensitivity and specificity of all those antibodies. What I just want to highlight here is that tissue transglutaminase has the highest sensitivity and specificity, the IgA specifically, which is why it's the most commonly used one. The deamidated gliadin peptide, when combined, IgG and IgA also has high sensitivity and specificity. How about upper endoscopy? We could use upper endoscopy to make the diagnosis maybe. There are certain genes that we see sometimes, loss of circular folds, mosaic patterns, scalloping, sometimes we call villus blunting. However, really, data shows that the sensitivity of those findings is low, and the specificity, even when we see them, is about 90% only. And that having a change on biopsy does not necessarily mean that the individual has celiac disease as well. How about duodenal biopsies, which is we talked about doing random biopsies when you see nothing, or even when you see something. How should we do those biopsies to optimize them? They should be done while the individual is still consuming gluten, because if we have a negative biopsy, we may say, well, they're on gluten-free diet. You know, is it negative now because they've been on low gluten-free diet before, and now we don't know what to do next. So I always call my patients when they get referred and I say, I know this is concerning, but please stay on gluten. Don't worry. You've had this for a while, likely. We will get you for endoscopy in a week or two. The other issue is that the disease is patchy, and I'm going to show you data on this. So we have to obtain multiple biopsies. We have to obtain biopsies from the bulb and the distal duodenum, and pathologists argue that we should label them separately because of certain genes that are seen in the bulb, like the Brunner glands and sometimes genes related to acid. And then in GI, we frequently, when we obtain biopsies, we obtain 2 biopsies at a time. So we put the forceps, we get a bite, then we push the forceps out again and get a second bite in the same forceps. And there's data that suggests that doing a single pass is actually better. And I'll share some of that data with you. So first, this is a study that tried to show that the disease is patchy. What they did is they looked at 110 symptomatic pediatric patients with supportive serologies, and they obtained biopsies from different sites in the duodenum, duodenal bulb, and different areas of the duodenum. And what they found is that when all these sites were biopsied, about 93% of the individuals ended up being diagnosed with celiac disease. When you biopsied only one site, only 50% patients made the diagnosis. So the disease is patchy. Another study looked at duodenal biopsies obtained from different sites, very specific sites. They describe them to endoscopists. You go here, you obtain it from this area and the other. And again, this study showed that the disease is patchy with about 10 patients out of 50, about 20% having patchy disease, and that if you didn't biopsy all those sites, you may miss them. So again, we should obtain biopsies from different sites. And that's some of the limitations when you see somebody who had biopsies before. You always wonder were the biopsies obtained appropriately or not. Another study, there were an older practice where we used not to biopsy the duodenal bulb. I think now most people obtain biopsies from duodenal bulb, and that's because some patients have disease limited to their duodenal bulb only, as shown in this study. Finally, the single biopsy technique versus double biopsy technique. When you obtain biopsies with a single biopsy technique compared to a double biopsy technique, the data suggests that you're increasing the yield of those biopsies. And you can see the differences here between the single and the double bites. Okay, I told you about serologies. I told you about biopsies. Can we make the diagnosis without biopsies? In 2012, the European Society for Pediatric Gastroenterology came up with guidelines based on some of the data that was published at the time. And they said that in individuals or children with symptom-suggestive celiac disease, if you have, you can check a TTG, a tissue transglutaminase IgA. And if it's negative, then either the individual doesn't have celiac disease or they have a false negative test. If it's positive, you look at the level. If it's less than 10 times the normal limit, then you have to do an endoscopy. If it's more than 10 times the upper limit of normal, you can do endomysial antibodies and HLA testing. If both are positive, you can make the diagnosis of celiac disease without endoscopy. If the EMA is negative and they have permissive genetics, or the endomysial antibodies are negative, then you have to do endoscopy. If the endomysial antibodies are positive, but they don't have permissive genetics, you have to wonder whether the HLA test was correct or not, or whether you should do biopsy. Maybe they have some rare form where they don't have any of those genetics that we know. If both are negative, you have to wonder if your TTG is false positive or not. In 2020, this got revised and they removed the HLA component. And now what they suggest is that you do a TTG. If it's positive, you do a second one with EMA. If you have more than 10 times the upper limit of normal and a positive EMA, you can make the diagnosis without endoscopy. This is hard to find, having both positive. Data suggests that not a lot of people have this. So this is a threshold that is really high to make the diagnosis without biopsies. So why do people argue that we should biopsy? First, the specificity of the serologic test is not 100%. And the positivity thresholds, they differ by labs and different kits. It's becoming more standardized, but it's still not 100% as far as we know. A biopsy confirmed celiac disease, there's observational data that suggests that it leads to more adherence to gluten-free diet. There's concern about the overdiagnosis of celiac disease, leading to those individuals who have positive serologies and negative biopsies. It's called potential celiac disease. It's an entity that we're not sure what to do with. There are multiple studies on it showing that sometimes up to 12 years, many of those individuals end up not developing, most of those individuals end up not developing celiac disease even. Those studies are mostly from children. We can use that biopsy to establish a correlation with serology, so we can follow our patients' serologies in the future and say, well, when their serologies were high, their disease was active, so we can use that. There is concern that we may miss the diagnosis of celiac disease complications, especially in individuals who are diagnosed late in life. Some people argue that you need that baseline to know what to do in the future if the patient don't improve, or something you can repeat a biopsy and see and compare the biopsies, how they changed. Now, I told you there are limitations to the biopsy in the first place. There's argument that in older individuals and individuals with symptoms, you may be missing concomitant diagnoses, cancers, Barrett's esophagus, other diagnoses. There's also the idea that endoscopy overall, especially in adults, is low risk, upper endoscopy. Finally, in certain countries, the legal coverage for gluten-free diet may be dependent on that. In the US, gluten-free diet education is not covered anyway, so it doesn't matter. But for clinical trials, most of the clinical trials actually require biopsy. So if we have a patient who's motivated to be involved in clinical trials, it's required to have a biopsy for diagnosis. Why do we argue not to biopsy? Access to endoscopy. COVID was a perfect example of limited access to endoscopy. You need to bring all those people and expose them to higher risk. We believe the data that I'm going to show you suggests that there's higher diagnostic accuracy. There's low risk for the celiac disease. Some people consider it low risk, and asymptomatic individuals, people who have no symptoms that I told you about earlier, may be hesitant. They will say, well, I don't have symptoms. Why do I need to have this in the first place? Cost of endoscopy, concern about sedation complications, the idea of there may be a concomitant diagnosis that is missed. There's really low yield from that endoscopy. The low risk of celiac disease complications, we talk about the complications, but I'll show you later that they're really rare at the end. There's concern about the biopsies not being optimal, so we may expose people to a biopsy and then we still miss the diagnosis. And then the experience of the pathologist at different places may vary, which may lead to variability in the diagnosis, because it's not only about obtaining the biopsy, it's also about how you process the tissue that may sometimes limit the diagnosis as well. What data do we have to support a no biopsy diagnosis in adults? This is a busy slide. This is a study from the UK in which they looked at adults that were referred to the celiac clinic who had positive serologies. What they did is they looked at their tissue transglutaminase antibodies. Let me get a pointer here. They looked at their tissue transglutaminase. The pointer is not showing, it's fine. So they looked at their tissue transglutaminase antibodies in the figure in the middle, and they compared that. I'm sorry, my screen is frozen here. So they compared that to the biopsies. Biopsies with MARSH 0 indicate that the individual doesn't have celiac disease. MARSH 1 means that they don't have celiac disease. MARSH 2, there's a lot of debate about it. And MARSH 3 indicates that the individual have celiac disease. What they found is that in those individuals who had tissue transglutaminase above 10 times the upper limit of normal, most of them ended having celiac disease. The positive predictive value was 98%, and this was using the MARSH 1, MARSH 2 as not diagnostic of celiac disease. However, when you have less than 10 times, you're all over the place, which is another reason that criteria is very specific of 10 times the upper limit of normal. This study also looked at another cohort. I'm going to take the pointer. I'm so sorry, it's causing freezing. This study looked at another cohort. They also used the same threshold. This was a cohort of individuals that were referred for EGD, and they ended having duodenal biopsies and then underwent testing for celiac serologies. Again, the 10 times upper limit of normal seems to predict the presence of celiac disease. That same study also had a multi-center arm where they collected data from centers actually around the world that also showed consistent data. Another study that argued that maybe it's about what is the risk for celiac disease in those individuals. Maybe they're all symptomatic, they're high risk. So they looked at different groups. This is a study from Finland, and they looked at different risk groups. So to the left, we have the group that had the highest risk. In the middle, we have the group that had moderate risk. Those are patients who have family history, maybe they're asymptomatic. And to the left are people who are identified through screening mainly. And they looked at their tissue transglutaminase. If it's above 10 and they have a positive EMA. And virtually all those patients at the end ended being diagnosed with celiac disease, as you see at the bottom. Now, in the group that had higher risk and had that criteria, 3 of them had MARSH 1 chains, not consistent with active celiac disease. What they did in those 3 patients, they exposed them to more gluten and they re-biopsied them, and they were able to confirm the diagnosis. So what the study argues is that across risk groups, it doesn't matter. If you meet this criteria, you most likely have celiac disease and there's no need for biopsy. Now, there are numerous studies. There's about 12 or 13 studies that did something similar using different thresholds. Those are the most recent ones. Okay. Does the presence of celiac disease antibodies, is it sufficient to make the diagnosis of celiac disease? As I said, in children, the European Society said, yes, do it. There's a lot of controversy about this. However, recently, not very recent, from 2019, the AGA has something called the clinical practice updates. It's usually expert opinion. And in that piece, actually, they argued that maybe we should start using the no biopsy diagnosis. Is it used? No, there's a lot of disagreement in the community. So I really can't give you a conclusive answer on this. What I do in clinic is I discuss with the patients and I tell them the benefits and harms of everything. Now, if they have symptoms or high risk features, like let's say they are losing weight or something, I may make an argument for doing a biopsy. If I have iron deficiency, I may make an argument to do endoscopy because there may be an alternative process to make that diagnosis, but it's usually a discussion and it's not as straightforward. But also remember that that threshold of 10 times with a positive EMA is really hard to reach. Okay. The last assumption, gluten-free diet is easy and has no consequences. And I will start with this figure from Beyond Celiac, which I usually show to my patients when I explain to them about the disease, so that maybe they can expect what they may go through. Celiac disease affects multiple age groups. Kids, adults, older, different age groups, even adults. So that may affect the kids when they go to school, how they can live in school. That may affect how their home is arranged. So maybe their siblings, they don't need gluten-free diet. They are the ones who cannot eat that pizza, while their siblings can eat that pizza, for example. There are a lot of things that impact that. For adults, going socializing, going to family meetings, going to all these things, a lot of patients end up developing food aversions also. They just don't want to eat because they're scared of eating also. So the psychosocial impact of this gluten-free diet alone, regardless of celiac disease, is really problematic. Gluten-free diet is expensive. This is the cost of an ounce of each of those substances in 2016 comparing gluten-free diet, the gluten-free version to the regular version. And you can see the cost maybe even more than 2 times sometimes. And this is, we're talking ounces, and this is 2016. In 2022, we have more inflation. Those numbers may look completely different now. It also depends on where you live. So in certain areas, it may be cheaper or relatively cheaper, I'll have to say, while in certain areas, it may be more expensive. So the cost of gluten-free diet is really high, even from a financial standpoint. Also, adherence to gluten-free diet. This figure is intentionally small, but what you have to see here is that those bars, that the adherence to gluten-free diet across different age groups is low or relatively low. And part of it is that it's really hard, it's expensive, it's difficult to do. There's actually a learning curve. So most of our patients, they want to do it all at the beginning. And I tell them, don't worry, it's going to take you a while. They do a little bit, they meet with a dietitian, then they meet with a dietitian again, just to make sure that they're doing everything correctly. Some people end up being overly restrictive. Some people end up being less restrictive. So it's usually a learning curve, but many patients end up not being adherent even, despite that. Additionally, gluten-free diet may be associated with certain nutritional deficiencies. So there's some data that suggests that those who are on gluten-free diet may be eating low complex carbohydrates, high simple sugar intake. They may be gaining weight. They may be having obesity even, low fiber intake. There are certain micronutrients that gluten-free diet may be lower at. So that's why we always advocate that individuals meet with celiac disease to meet with a dietitian to make sure that they're not missing any of those things. There are other reasons that we need to be accurate in our diagnosis. Not only that gluten-free diet is restrictive and difficult, there's an increased risk mortality. There's data that suggests increased mortality. There's data that suggests increased risk of certain cancers. There's a concern about refractory celiac disease. And finally, there are the medications in the pipeline. As I mentioned, most of those medications, maybe insurance none of them is available, but it may be required to have a biopsy to confirm that diagnosis before being able to prescribe some of those medications if they end up being expensive, which will likely be the case. Increased mortality. This is data from a large database from Sweden. What they found is that individuals with celiac disease compared to their siblings had higher mortality, all-cause mortality, even with adjustments. The risk of malignancy. This is mostly based on observational data from celiac centers. What it shows that individuals with celiac disease are more likely to have lymphoproliferative disorders and small bowel adenocarcinoma. Those are usually diagnosed late in age, individuals who are diagnosed late. The other thing is that the data suggests that those individuals without histologic remissions, those individuals with active disease have the highest risk. Now, again, this is all observational data because those conditions are rare in the first place. The relative risk is 3, but the absolute numbers are really small, which I always tell my patients about so that they don't, hoping to minimize the anxiety that comes with this assumption. And there are medications, as I mentioned in the beginning. There are multiple medications coming in the pipeline. Starting in 2007, the first trial came, and now there are many trials happening targeting different areas. So it's very important to have an accurate diagnosis. One, because the disease has an impact on our patient's life. Gluten-free diet, even when prescribed not for celiac disease, it's very restrictive. So you need to make sure that you really need it. And then there's clinical outcomes that are important for our patients that may be impacted based on that diagnosis. So in summary, celiac disease is a common condition and may be underdiagnosed, especially in people of color. A symptomatic response to gluten-free diet has no role in the diagnosis of celiac disease. Maybe it increases the pretest probability, but it really doesn't have a role. We don't use it to make the diagnosis. Asymptomatic individuals with celiac disease, as I showed you, may still benefit at least from quality of life standpoint and symptoms standpoint from gluten-free diet. Evaluation of celiac disease should be completed prior to starting gluten-free diet. So if somebody is suspected to have, we really should start the evaluation. We can start it as soon as possible, at least here at WashU. A no biopsy diagnosis of celiac disease based on serologic testing is still an area of controversy. However, if you want to do it, really have a good discussion with your patients about it. And we need to explain the benefits and harms of everything as we do always in medicine. And the criteria is very strict. So not a mildly positive TTG. It needs to be 10 times upper limit of normal. For example, the upper limit of normal is 14. So you need to have above 140, which is not seen frequently. The accurate diagnosis of celiac disease prior to starting gluten-free diet is critical. There's a patient burden from the diet, and there are outcomes that are associated with this as well. I'm happy to take any questions. Yes, sir. Sure.
Let's have 1% of patients Olmsted County that are normal labs and no symptoms. Is there any evidence that those people are able to develop adenocarcinoma or anything? And if not, why do you say those 1% of the population want to die? Like for me, I think it's a personal. If it's just a symptom-based thing, it's a personal decision. But if it's they're at increased risk of cancer, then that's something we really should reinforce.
Thank you, Jeff. So the question is, in that 1% from Olmsted County who did not have symptoms of celiac disease and had abnormal serologies, is it really important for those people to be on gluten-free diet? Is there any data that when we do that, we're reducing the risk of cancer? The answer, we don't have data. The data even on cancer is very minimal. What we know is that in those studies that in which cancer diagnosis was made, they were usually diagnosed in their 50s and 60s. So is it possible that they had that celiac, that positivity of the autoantibodies for a long time, but they were not diagnosed and they were just found late? We don't know, but that's the assumption because they likely had the disease for a long time. They just didn't know about it. But we don't have concrete data on this, no. It's all assumptions. And unfortunately, the event rates is so small that it's so hard. I think the only way to solve this is needing collaboration between institutions to figure this out. The other thing is there's, for example, there's data from type 1 diabetics. They're following a lot of type 1 diabetics for risk of celiac disease. Maybe those cohorts in 20, 30 years will have information from them about the risk of having celiac disease, especially in those who end up not following a gluten-free diet.
Yeah, so the risk of neuropathy associated with insulin it's been pointed out for but that was when the diagnosis symptoms, diarrhea, blah blah blah, not to say symptoms. So that's my comment. Just respond. That's the data. The newer data suggests that there is a chance to develop blood clots.
But those are, I think, the discussion here is that we think that those patients have symptoms, but I think those had symptoms around the time of diagnosis as well. So not all their life, relatively. So a lot of these patients were diagnosed with celiac disease in few years. They were diagnosed in their 40s or 50s from the data. And then in few years, they developed the T-cell lymphoma or
Yeah, I guess we don't look at the data.
Yes. Yes, we don't know. Yeah. 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 So, thank you for this question. So I try to, restrict my talk for the time, but there's some patients who have, actually, there's a concern about IgA deficiency in individuals with celiac disease. It's suggested to be present in about 5% of patients with celiac disease. And in those individuals, the suggested workup is that if you have, so there are algorithms for lab testing. Our lab here at Barnes doesn't have that, but certain labs commercial labs have this. So if you have a negative tissue transglutaminase IgA, their next test is to obtain an IgA. And if the IgA is low, they obtain an IgG test, and that's usually a deamidated gliadin peptide IgG. My practice here is to obtain both TTG and IgA at the same time when I'm obtaining the labs at Barnes. If it's low, then I usually call the lab the same day and I say, this is low, because the IgA comes back pretty quickly compared to the tissue transglutaminase. And my practice is I call the lab and say, can we add this, please? And they are usually able to add it.
So the second question, there's this concept of latent celiac disease.
Mm-hmm.
You have serology that's positive, biopsy. So what do you tell those patients? And this means that you're getting serology that's positive.
Yeah, so there's this interesting concept of latent celiac disease or potential celiac disease. So those are individuals, I mentioned that briefly, but those are individuals who have positive antibodies or negative biopsies. I was really hoping to be able to include this in my talk also, but I did not at the end. But there's data mostly from pediatric populations where they followed some of those patients up to 12 years. Many of them end up still not having celiac disease with fluctuating levels. Now, I think some of the studies reported 20%, 30% ending having celiac disease at some point. However, in those individuals, there's a lot of controversy about what to do. Many people suggest if the individual is symptomatic, maybe starting them on gluten-free diet. Some of the studies did this. I think a study from Finland, they randomized people to gluten-free diet and not gluten-free diet. Unfortunately, many of those didn't have biopsies in the first place. And the suggestion, and there was no blind, so the suggestion that those who had symptoms felt better when you start with gluten-free diet, but you don't know, did they really feel better or there was some, placebo effect from starting the gluten-free diet? Yeah, but my practice tell the patient, I don't know if you need a gluten-free diet. There's no evidence of organ damage here. I suggest usually to follow up and do nothing and keep an eye on their serologies. If they increase a lot, or maybe we can repeat it at biopsy, let's say at the time of their screening colonoscopy or something. I try to find the time to repeat their endoscopy to see if there's evidence or if they develop any symptoms as well.
So, Osama, that was a really great talk. So all the associations with the other diseases, the thyroid disease, the osteoporosis, are those related autoantibodies and autoimmune conditions? Are they related to dietary changes or malabsorption, or what's the connection?
So the question is about the association with all these different conditions. There are variable reasons. Some of them are related to the HLA type in the first place, like type 1 diabetes, for example. But some of them are related to the change from malabsorption, for example, or the inflammatory process, for example, osteoporosis. There are many theories. Some of them is that, well, maybe it's a chronic inflammation, the same way we see in patients with Crohn's disease or ulcerative colitis, or maybe it's related to vitamin D deficiency that happening over time. But it's really multifactorial.
Other questions?
Yeah, so the question is about the HLA typing. One, is it expensive? I think it is expensive. There are also, unfortunately, variable versions of it, commercial versions and other ones. It is expensive. I usually have a discussion with the patient before I tell them, hey, we have two options. One, you restart gluten and we see what happens with your antibodies. And I also tell them to do that slowly. So I will say, well, eat one slice of bread daily, and then we increase it over time. And then we may check the serologies. If they still have questions, I may then use the HLA. If they're refusing to try gluten completely, I usually tell them, and some patients will refuse still. They will say, no, I don't want to do anything. But I usually suggest, frequently I'm able to convince them to do the test. Dr. Pathy.
Great. So I have a question. You mentioned lots of people are already on it. You have someone who works for abdominal pain. Do you do biopsies with biopsy?
If they are on gluten-free diet. So the question is, if somebody is referred for endoscopy and they have, let's say, abdominal pain and they are already on a gluten-free diet, I may still do the biopsy because I didn't mention it here, but the biopsies, some data suggests that the biopsy never normalize up to 5 years sometimes in some patients. So if I find change, that may raise the question of the diagnosis for sure. So I may still do biopsies, yeah. There's a question in the Q&A. Can you comment on the status of HLA testing in regard to small molecule aldomet as a treatment in humans? I actually don't understand the question completely. Yeah.
Let's take this question. Maybe they can clarify it in the chat.
Yeah. Yeah. So this is also, I will say, a hot topic, because how do you follow up those patients? Do you really need to biopsy them all? Because previously we say, oh, biopsy everybody in a year. But then the data says, well, in a year, not everybody will have normalization of their histology. Actually, as I mentioned earlier, some patients will have no symptoms at all. They have no evidence of malabsorption at all, up to 5 years, and their biopsies don't normalize until 5 years. So I usually, my utilization for repeat biopsy is the following. If a patient is continuing to have symptoms after a year or 2 years, a year, and they have malabsorption, sometimes 2 years also, it's always an argument, discussion with the patient, not an argument. But if they still have symptoms, and especially if they have evidence of malabsorption, I may provoke the diagnosis of refractory celiac disease. Now that usually requires a lot of workup. I usually ask them to meet the dietitian first, say, and the dietitian's job here is really investigational. Are they consuming gluten or not? Is there possible cross contact? Is there possible sources of gluten? If none, and there's no other explanation than endoscopy that shows persistent villus atrophy, confirms the diagnosis of, or suggests the diagnosis of refractory celiac disease. In terms of follow-up, there are different algorithms suggested. Some people say repeat serologies in 4 months, and then in 6 months, in 12 months. I think I'm becoming looser over time. I used to do it every 4 months and 6 months. But the question is, does it really change things, right, for the patients? I usually do it at 4 months just to see some change. If there is some change happening, it means that the patient is likely doing something. That's what we think, at least. If there are no changes happening, I'll tell the patient to meet the dietitian again for sure, to make sure they're doing things correctly. Some patients never normalize their serologies, though. They stay at lower level, less than 2 times the upper limit of normal. Can I change the slide for?
Yeah.
Yeah. Oh, it's way back. So the question is, I showed a slide of the sensitivity and specificity and positive and negative predictive values, and why is it different? Between the other slide where I showed that it's the positive predictive value maybe 100%. So the reason is the thresholds used. Yeah, so that's a 10 times upper limit at normal. Those other studies that were using the regular threshold that we use, usually 14. And those studies also, from the first slide, they included different kits that were not as standardized as we have now. The recent studies that we have, so this study from the UK used the most standardized kit in Europe, for example. Okay, but again, even with that standardized kit, the threshold is 10 times above limit of normal, not an abnormal test. Okay, another question. With regards to biopsy in asymptomatic non-CD patients in the studies you mentioned, could it be that we are seeing a dose response pattern to high level gluten in Western diet that has no long-term negative health outcomes? Could there be biopsy change to exposure to other diets? Biopsy change. So the question is about biopsy change in asymptomatic non-CD patients. Oh, so you're talking probably about the MARSH1 chains that are seen. The MARSH1 chains, which is essentially increased epithelial intraepithelial lymphocytes, is not a specific finding. It can be seen in other conditions. It can be seen with the use of NSAIDs. It can be seen with the presence of H. pylori. There are so many reasons to have some of those biopsies changed. Even villus atrophy is not a specific finding for celiac disease. There are many conditions that could cause villus atrophy that are not celiac disease. So some medications that we use cause villus atrophy. An example is olmesartan. Other examples include some of the immunosuppressive medications that we use, for example, azathioprine, mycophenolate. They all could cause villus atrophy. There are other conditions, autoimmune enteropathy, infections such as giardiasis, other sprues other than celiac disease. So the evaluation of the presence of villus atrophy includes a lot of not only celiac disease. There are so many other conditions that could cause that, but it is core of the evaluation of celiac disease, I would have to say. Okay.
Yeah, this is probably all we have time for
Okay,
now. But
okay.
Thank you so much.
Thank you. Thank you for having me. Thank you.